Users, and I'm pleased to welcome you on behalf of myself and my co-chair, Sergei Dvoryak, who you will hear from in a little while, to this session on evidence-based prevention for injecting drug users. And I wanted to highlight that the program noted the return of the ban, the federal ban from the US government on needle exchange funding. So the session today is going to do two things. It is going to touch briefly on what is lost in that ban, and that is in the person of our first speaker, Stephanie Strathdy. And then it is going to move on to hear from people from 3 different countries and 3 different perspectives, talking about how we can move forward even without US government support, and some of the promise and challenges of their approaches as they do that. So I want to remind everyone that this session is being taped for the Kaiser webcast series, and if you ask a question, your question will also be audible. We will have presentations first and then go to questions at the end. So without further ado, let me introduce our first speaker. Stephanie Strathdy is Associate Dean of Global Health Sciences, the Harold Simon Professor and Chief of the Division of Global Public Health in the Department of Medicine at UC San Diego School of Medicine. She's the recipient of a NIDA, National Institute of Drug Abuse Merit Award, a researcher known to many of you for her groundbreaking work in multiple countries on questions of needle exchange and its efficacy, HIV prevention and HIV treatment for injecting drug users, and I'm very pleased to give her the floor. Stephanie.
Thank you very much. And before I begin my presentation, I would like everyone in the room to stand in solidarity for all of the people who use drugs and are sex workers who have been excluded from the meeting. We respectfully ask the IAS to ensure that the meetings don't happen in countries that repeat this exclusionary policies. Thank you. So thank you for the very kind introduction. And thank you to a number of people who have contributed slides, data, information, and advice for this presentation. Let's start at the very beginning of the AIDS epidemic. This is the very familiar pattern of the AIDS epidemic by risk population in the United States since the epidemic began. And I'll draw your attention to this blue line, which are reported AIDS cases among people who inject drugs. Now, this epidemic peaked here, and this is reported AIDS cases, in the early 1990s and then started to drop off. And some of that was obviously due to the introduction of HAART, as we've heard a lot about. But something else very interesting and important was happening. Even though the first needle exchange program in the US was implemented in 1988, the North American Syringe Exchange Network started collecting data on the numbers of syringes exchanged in the United States. And as you can see, that number has increased steadily since 1995, and there are currently 194 needle exchange programs known to NASEN in the United States, with about 35 million syringes being exchanged. That's extremely impressive if we compare this against the policy backdrop, because, as Daniel mentioned, a congressional ban on funding, federal funding for needle exchange programs began in 1988. And this ban was to be upheld unless the Surgeon General could determine that needle exchange programs could reduce HIV incidence and prevalence. The ironic thing that for a short time in the 1990s, there was even a ban on funding for evaluation of needle exchange programs. So it's the ultimate catch-22. You've got to show that they're effective, but you can't do the research. Luckily, this ban didn't last very long, because this was actually a very pivotal time in the AIDS epidemic when the cases among injection drug users were rising their most steeply. And the ban played on. Decade after decade, this ban was upheld until 2010, with much fanfare. The Obama administration took the courageous route and overturned the ban. This was a moment of great achievement. However, at the very end of December in 2011, just a short while ago, in backdoor conversations when all of us had sugar plum fairies dancing over our heads, this ban was reinstated, and we all woke up in 2012 wondering what the heck happened. We don't know what the impact of this is going to have on the HIV epidemic among people who inject drugs in this country, but surely this can't be good. So why the heck is there still controversy about needle exchange programs? Well, let's examine the data and make our decisions based on science rather than morality. The purpose of needle and syringe programs is that they provide sterile syringes in exchange for potentially contaminated ones in order to reduce syringe sharing and reduce the time that syringes are circulating in the community where they could infect people. But the other important role that they play is to provide contact for injection drug users to other health services for people who inject. So we're talking about drug treatment programs, et cetera, and we'll talk about those in a moment. I could spend the rest of the day, even the rest of the week, talking about studies that have shown that needle exchange programs consistently are associated with reduced HIV prevalence and incidence. These are just a few of the papers that have been published on this topic. In fact, there is 8 congressionally funded studies and reports and several international reports that have concluded that needle exchange programs do consistently reduce HIV incidence and prevalence. And this is a report from the WHO, the Institute of Medicine, and most recently a report from the Global Commission on Drug Policy. In contrast, there's no evidence that needle and syringe programs are associated with drug use, crime, discarded needles on the street, permissive attitudes towards drugs among youth, and the formation of high-risk needle-sharing networks at the needle exchange programs, or most recently, delayed cessation of drug use. These are all studies, incidentally, that have been funded by the National Institute on Drug Abuse. Now, fanning the flames of this controversy were 2 papers, one from Vancouver, which is my own work, and that of Montreal that came out in the late 1980s. And these studies showed that there was high incidence in these cities among injection drug users of HIV infection despite large-scale needle exchange programs. I can tell you the Vancouver report said that needle exchange programs are a very important component of what should be a comprehensive HIV prevention strategy, but they can't alone pretend that they're going to keep a lid on an epidemic in the absence of other programs such as drug treatment. The Canadian response was a sensible one. They expanded needle exchange programs. They expanded opioid substitution therapy and voluntary counseling and testing. They removed restrictions on the syringes that were exchanged at needle exchange programs. And much later, they have offered alternative harm reduction strategies, such as safe injection programs. In the United States, the response was the direct opposite. And here are just 2 letters of Congress that were sent around in 1988-89. And in fact, my paper was entered into the congressional record word for word with the opposite interpretation than the publication. This was certainly the low point of my career, and I've been fighting this interpretation ever since. The sad thing is that because of this continued ban, needle and syringe programs have difficulty providing other ancillary services that are just as important as the syringes themselves. While a good percentage of them include substance abuse treatment referrals, voluntary testing and counseling for HIV and Hep C, far fewer are able to offer Hep B vaccinations, STD screening, on-site medical care, or TB screening. And now the ban plays on. We've had 2nd and 3rd generation needle exchange evaluations, and this is a paper from Hannah Cooper and colleagues that shows the spatial access to syringe exchange programs in 1995 in New York City versus 2006. So the darker neighborhoods are neighborhoods where there is greater access to syringes. And Dr. Cooper and colleagues showed that living in a neighborhood with better spatial access to needle exchange was associated with less needle sharing. In Iran, there's been some interesting work comparing neighborhoods without needle exchange to those with needle exchange, and those without needle exchanges are much more likely to see higher levels of syringe sharing, higher network sizes of injection drug users, and in people who have ever shared injection drugs in prisons. Moving on to China, we've seen very impressive data, this from Dr. Zhang and colleagues, that show in the Yunnan province, where some of the HIV incidence among injectors has been the highest, that the annual HIV incidence without needle exchanges would have continued to climb, but in the presence of needle exchange, it has stabilized. Some very interesting data has also been published recently by Dr. Vickerman and colleagues from the UK. And now hepatitis C prevalence is very hard to change because it's more infectious than HIV through the parenteral routes. But Dr. Vickerman has showed that if you have optimal coverage of opioid substitution therapy and needle exchange programs, for example, over 10 years, you can reduce hep C prevalence by 60%. So if you move on to the Ukraine, we also see very interesting data, and it's very impressive. This is from David Wilson and colleagues, who are going to be presenting these data on Thursday at the conference. They have compared the outcomes of needle exchange programs on HIV and hepatitis C. And as you can see, there's been a significant impact on prevalence, infections averted, quality adjusted life years gained, and huge cost savings over the lifetime. In fact, these same colleagues have examined the impact of needle and syringe programs on syringe sharing HIV and hep C incidence, not just in the Ukraine, but in 8 countries in Eastern Europe and Central Asia. And they will show on Thursday, convincingly, that syringe sharing levels decreased with increases in per capita syringe distribution, most impressively for the Ukraine, but for all 8 countries. And in fact, needle exchange programs averted 10 to 40% of HIV infections. And when hep C was also considered, all of them these programs were shown to be cost effective. And then finally, Degenhardt and colleagues showed that when there is optimal coverage of opioid substitution therapy, needle exchange programs, and antiretroviral therapy, that there could be up to a 63% reduction in HIV incidence over the next 5 years in a hypothetical epidemic. Now, all of these data are certainly very convincing to me and hopefully to you, but if we look at the coverage of needle and syringe programs and we look at the number of syringes that are provided per person who injects drugs around the world, we see an appalling figure that it's unbelievably low coverage, only 22 syringes distributed per person per year. And in black are the countries that absolutely have no evidence of having a needle and syringe program. And the darker colors in red are those very few countries that offer more than 200 syringes per person. Now, all of this is even more worrisome when we realize that in the countries where we have PEPFAR activity, and we're speaking here about Russia, Ukraine, Vietnam, Tanzania, and Kenya, these are some of the countries where HIV incidence among injectors is rising most rapidly. And unfortunately, PEPFAR funding cannot be used to support syringe exchanges at all, never has, and with this ban, it means that they never will. This is a threat to an AIDS-free generation. PEPFAR funding needs to include syringes. So in conclusion, a quarter century of empirical research provides overwhelming evidence that needle and syringe programs can effectively reduce HIV incidence and are cost effective. Yet globally, coverage of needle and syringe programs is abysmally low. The reinstated ban on the use of congressional funds to support these programs is a decision based on politics, morality, and not science. Such deadly public policies fuel HIV epidemics rather than containing them. Now, the whole conference theme is about turning the tide. What we need to do as activists and as scientists is stand together in solidarity and make sure that this tide doesn't wash over us. Thank you.
Hello. Now it's my pleasure to introduce next presenter. This is Anya Sarang, who is a public health activist from Moscow, and by the way, my personal friend. She's absolutely wonderful person. She's founder of Andrei Rilko Foundation for Health and Social Justice for the past 15 years. Anya's work has focused on developing and supporting the emerging harm reduction movement in Russia, and she's working in really very tough conditions.
Thank you very much, my friend. There is a timer. Does it work? So how do I find my presentation? Do you know how to find it?
I think click on that number.
This one. Okay. Doesn't work. It works. Okay, so yes, I will be talking. I mean, I hope it never happens to you guys in America, but I will be talking about our work, our attempts to provide access to needles and syringes in a very tough political situation without access to basically any funding or political support. And I will be talking about my own organization, Andrei Rilko Foundation for Health and Social Justice. And in this presentation, I will focus on our service provision to drug users in Moscow. So just some brief information about the city. It's a huge city. The official statistics says it's 12 million people, but in reality, it's maybe between 15 and 16 million of population of the cities, 10% of the Russian population and 3 populations of countries like Georgia, 4 Moldovas, 10 population of Estonia, and so on. So it's really a huge city. Moscow remains one of the top most expensive cities in the world. Now it's on the 4th after some Japanese cities, but it keeps moving from the 1st to 4th position on this list. And it's also the city with most billionaires in the world. And our ex-mayor's wife is the 3rd richest woman in the world. So it's quite a, advanced city economically. Now let's look at the epidemiological situation. We have estimated around 1.5 drug users, of whom about 100,000 are injectors. People mostly use opioid drugs such as heroin, street methadone, pharmacy opioids, and poppy seeds preparations. The official number of people with HIV is over 40,000, but we know that at least 25% of IDUs don't know about the HIV positive status. And the prevalence of HIV in injecting drug users, while lower than in many other cities of Russia, continues to grow. So from 14% in 2004, it grew to almost 20% last year. Also, HCV incidence is quite high, and also prevalence in IDUs is almost 70%, and we have TB epidemic growing. In terms of politics, we don't have any political support to harm reduction programs whatsoever on the federal level. So, for example, the opioid substitution treatment is illegal in Russia, and needles and syringe programs are considered as threat to the national drug control strategy. However, unlike substitution treatment, needle and syringe programs work in Russia with the support of Global Fund, and some are supported by HRD. Legally, it's a gray zone, so none of the programs have been sued for providing needles and syringes, but the government always assumes that it's not very legal activity. Especially, this policy is very hard in Moscow, where traditionally, since the late 90s, the city government was opposing needle and syringe programs and harm reduction programs. And there was even a myth that needle and syringe programs are illegal in Moscow. So for many years, none of organizations were trying to do the, even attempting to do these programs, or those who attempted focus on advocacy and trying to convince the decision makers on necessity of these programs, and all these attempts have failed. However, this is not true, and needle and syringe programs are not illegal in Moscow, although they are not supported at all. But we do have kind of documentation, what is called like an order from the Moscow Department of Health, which prohibits realization of harm reduction programs on the basis of the municipal medical institution. So it doesn't relate to us because we are a non-governmental organization, but none of the municipal medical institutions cannot run any needle and syringe program. So as you can understand, this city would never fund us or anyone who is doing the work like that. So we at Andrei Rylkov Foundation, we're a very small grassroots NGO. We are fighting for health and human rights of people who use drugs in Russia. And our mission is to promote and develop humane drug policy based on tolerance, protection of health, dignity, and human rights. We focus a lot on advocacy and human rights campaigns, but we also have the small needle and syringe access program in Moscow. Like, we are really tiny, we don't have an office, and we don't have like you know, some facilities. So we work in the modality of on-foot outreach. We go to the outreach visits every day in the evening, and we provide our clients and participants with syringes, condoms, HIV. We do HIV rapid tests. We give them ointments, bandages, naloxone, and we counsel on the issues of HIV, of drug dependency, and refer to medical institutions. Also help them to get into the institutions because it's very challenging for drug users in Moscow. We have a medical specialist who also is almost a volunteer. He goes out with us 1 or 2 times a week. And we have like legal counseling and other services on request. We also do training for drug users, which is also a bit challenging because we don't have our own space, but we try to organize it either in the squads or flats of drug users or in some convenient locations. We're not like a huge program, as you can understand, because we basically operate on very like partisan small scale level. So the numbers are not huge. Last year we reached almost 800 people, of whom 300 was women. We provided 40,000 needles and syringes and 3,000 condoms. Did 41 tests, but I think we actually did more, just like didn't go into the report, and provided consultations on HIV. And also on drug treatment. So we do a lot of counseling on drug treatment and referral to the local narcological clinic and NA groups and whatever help, little help is available for people on this issue. Now, challenges. I must say that we operate already this program for 3 years. We never had problems with the local police or whatever governmental, you know, scary people. They just don't show up in the same places where we are. So we never had this kind of problems. Of course, it's kind of like not convenient sometimes that we don't have an office or convenient storage of materials, so people have to store everything in their own places. And so therefore, to each visit, they cannot carry enough material. So like the visits are 2 hours, 3 hours maximum, because we cannot carry enough syringes with us. We don't have regular spaces for trainings, which is also kind of solvable problem. And of course, one of the most serious challenge for us is seasonal, because, for example, last winter, the guys couldn't just be outside on the street for more than half hour. It was like minus 40 Celsius, and when they were trying to do HIV rapid tests, the buffer would just freeze, you know, so it was impossible, of course, to talk to people, and this weather was going on for 2 months, or 1 month at least, and then a little bit better. Also in Moscow, while it's like the richest and hugest city, there is a really serious lack of any services for IDUs or homeless people. Of course, I said that there is no OST, and so it's very difficult for people to stay in hospitals. So the situation with poor people is actually horrible. And of course, one of our main challenges is unsustainable funding, because this is just one picture from our work. Well, because we are not funded, like we don't have any regular funding from foreign sources as well. We have global fund in the country, but the managers of the global fund program also refuse to fund us because we don't have like good relations with the city authorities or because of the political situation in Moscow. So we operate, sometimes we don't have funding at all for months, sometimes we receive some random money or some donations, and last year we received a big donation, Crystal of Hope Award, and that keeps us going for this year. But there are also good sides, and I'm sure that many people who work in needle and syringe programs could appreciate many of them. For example, we don't have to code our clients, which we think is like the greatest achievement, and we are all very happy about it because we don't have this like strict donors, requirements. We don't have to fill 100 forms, write 1,000 reports. So we just report by email to each other every night and say what's new on the drug scene. And we don't have to like really emerge into bureaucracy and the stupid requirements of the clients. And we have like pretty much horizontally self-management. We don't have some bosses and someone telling us what to do, and that's why we also love each other. And there is not much like work-related stress, so not much burnout. I said already about the funding. We were funded by UNODC for 2 years when they had the HIV prevention program, and now we are funded from the Crystal of Hope Award, of which we are very happy. Now we also decided to try a small micro-donation campaign. It's kind of like both fundraising and solidarity campaign, so we distributed information about our program and our challenges throughout the world, and we were collecting money through this global giving, very convenient website, and we already collected like 1/6 of the sum we needed for the mobile exchange unit. This unit we want to buy just to be able to provide some services in winter and take care of our clients. And this is just some political, political card that we made for this campaign. I made them. And now really the Russian government is going a bit like, absurdically crazy. Now we have censorship of internet, and our own website was closed in the beginning of this year by the government, just illegally shut down by the Federal Drug Control Service. Now also we have crackdown on the NGOs, and this law was accepted just 2 days ago, and now all the local NGOs that work in Russia using the foreign funding are considered foreign agents. So, just crazy things are going on. We have no money from the federal budget for HIV prevention among drug users. And now it's also illegal to protest at all, because for any kind of public protest, there can be very strict punishment. So I don't know what will happen in Russia, and as I said, I hope that despite the federal ban, this kind of situation will never happen in the United States. But that's how we operate, and I hope this information could be useful for you guys. Thank you.
Thanks, Anya. So we've heard about the US ban, and we've heard about the Russian, not quite ban on needle exchange, but ban on many things related to getting information out to drug users or to operating effectively. And you may say, well, that's what happens when you have a big, powerful government. But our next speaker is going to complicate that picture a bit. because China is a country that simultaneously has pursued a fairly strict anti-drug policy, but also leavened that or mixed it with a great measure of pragmatism. And we have heard a lot about the scale-up of methadone in China, but relatively little about the scale-up or the operation of needle and syringe programs. So our next speaker, Xiaobin Zhao, will tell us about that. He has worked on HIV and needle exchange programs for more than 10 years, including on a number of NIH-funded interventions. He is a member of the National Methadone Working Group on China. He is affiliated with NSEPs. His colleague from NSEPs is speaking at another session next door. So for those of you who came to hear about China, we're very grateful to you for coming to this one. And I'd like to give the floor to Xiaobin Zhao.
It's my great pleasure to be here to talking about China's needle exchange program among the drug users. First of all, I want to thank Dr. Wu Zhenyu, the Director of National Center for AIDS Control and Prevention, China CDC, and his team, the China's National Needle Exchange Program Working Group. With the hard work of the team, China's government support needle exchange program is possible. And I also want to thank for the great support from the Ministry of Health of China and also from the international community, for example, the Global Fund, United States, and the UK. And also, really appreciate that the conference gave me opportunity to be here to share China's experience of the needle exchange program, and I want to hear your comments and suggestions on China's needle exchange program. When China starts the NEP, there are so many drug users are living in China. There are more than 1 million drug users. And the HIV prevalence among them is quite high. It's about 6% nationwide. In some areas, the HIV prevalence among the drug users is higher than 15%. So, and at the same time, the high-risk behavior among the drug users is quite high. For example, they like to use the drug with their friends, share the needle with their friends, but they dislike to use condom when they have sex. So it's very dangerous for them to get HIV infection. NEP have been approved a very successful strategy to reduce HIV infection among the drug users. So when China take action to combine the HIV spread among the drug users, NEP is one option for China. I think China initiated NEP based on the small experience and then the large-scale experience. For example, in 1997, Dr. Wu did a very, very small pilot study to look at if the village or other community member accept to do HIV intervention among the drug user or not. And in the same time, the first workshop on NEP was hosted by the Chinese Preventive Medicine Academy, and also with the support from the Ministry of Health of China in 1999. Scale-up pilot study was conducted in 2 provinces. And the result of this pilot study shows that the NEP can reduce HIV risk behavior among the drug user, and also community members think, oh, it's okay, NEP is okay, they can accept it. So in 2000, with the support from the international community, China conducted NEP in 4 provinces. And then in 2003, after the announcement of the 4-free-1 care policy, NEP was scaled up nationwide. From this slide, we can see that with the progress of NEP in China, Chinese government have issued very key policy and document to support to facilitate the NEP. For example, the 3 5-year AIDS action plan, and also in 2008, the web-based data management system have been set up nationwide. The 2 documents on the left side of the slide is issued by the State Council, the central government of the China, which is a key policy and document to support the NEP in China. And the gentleman in the right side of the picture is a former Ministry of Health of China. He visited to the NEP site to look at the operation of NEP, and he talking with the staff there. In this map, the yellow color represents provinces that have set up the NEP site. So we can see that so far there are about 1,000 NEP sites nationwide, and there are more than 44,000 drug users have been covered monthly. Now I want to talking the operation of NEP in China. Before 2010, China's NEP was supported by the Chinese government and also supported by the international community. After 2010, results from the international community can be considered. Then now China's NEP is mainly supported by the government budget. And in China, because China is huge, and in the different places, the NEP is operated by the different organizations. For example, by the peer educator, by the CDC staff, or by the NGOs. And the health users in the community, if they want to join the NEP, then they can find the NEP site very easily. Just as I mentioned in the previous slides, China set up the web-based data management system, and NEP is one component of this system. All NEP sites in China are required to report data monthly. For example, how many drug users came to the site to exchange needles, and how many needles condoms have been distributed and how many needles have been returned. So through this system, the National NEP Working Group can have the overall picture of the NEP in China. In terms of challenge, I think misunderstanding and debate on drug use and on NEP is might the most one. People might have the different opinion on drug user, and others may think that NEP encourage drug user in community. And also, in China, we don't have the comprehensive evaluation on the role of NEP in HIV prevention. So, and another issue is we don't know which operation model in China is better. Peer education is better, or CDC staff is better, or other NGO. We don't know. So in the future, I think more effort need to be decrease the negative attitude toward the drug user and NEP in China. And we have to do the comprehensive evaluation on NEP in HIV prevention in China. And also, we want to encourage target population, for example, the drug user and other NGO to participate in the NEP. So I want to end here. Thank you.
After China and Russia, we will go back to the United States. And let me introduce next presenter, Paola Barahona. She is project director at the District Columbia Appleseed Center for Law and Justice, where she works on health policy issues, including HIV, AIDS, and syringe access. Before that, she directed the harm reduction advocacy campaign for Physicians for Human Rights and was the founding executive director of Prevention Works, a syringe exchange and harm reduction organization that operated here in the District of Columbia. And her presentation titled Addressing the Needle Syringe Exchange Program Shortfall in the USA, Local Problems, Local Solutions. Please.
Thank you very much. How do I do this? What do I do? Okay. Well, I would like to thank the IAS for inviting me to speak about syringe exchange in Washington, D.C. I'd like to welcome you to my city. How do I? Okay. The alternative title, more what I think of this, is Syringe Exchange in Congress's Backyard. I'm going to tell a bit of a story of how syringe exchange has evolved in this particularly unique location. Having worked on this, I've been working on advocacy at the local level here in DC for 14 years, so I've seen a lot of change and back and forth and quite a lot of battle. It starts off with the fact that the District of Columbia is subject to oversight by the United States Congress. So that's where the trouble starts. So what this means is that, we have locally elected officials. We have the mayor, we have the district council. The mayor prepares a budget for the city based on what he sees as the priorities. The council passes it, and that's where things should go. But no, after that point, it then has to be approved by the House, the Senate, and signed by the president. That's where things get a little bit mucky. So this is where if you hear some local advocates, we talk about budget autonomy. This is what we're asking for, where we can just set our own budget and not have any intrusions. And I'll show you how that has worked to our disadvantage. Some of the background on needle exchange in Washington, D.C. It started, like most places around the country, sort of mid-late 80s by grassroots activists doing what they need to do, sort of act up, showing up, and recognizing how we need to fight the epidemic. Then in '92 was our first attempt to have kind of legal needle exchange. It was a failure. It was very government-oriented. You had to go down to the Department of Health, answer a bunch of questions, and get your syringes there. You know, about 50 people enrolled in that. It was not very effective. So then the next attempt was in 1994, the legislation which allowed a community-based organization to operate these services. Then it kind of got bogged down in bureaucracy, and it took a couple years for the money to get through, but then we had actually community-based syringe exchange program at Whitman Walker Clinic, a large AIDS service organization in the District of Columbia, with funds from the District of Columbia. Now, Stephanie had made mentions of the federal ban that was put in place in 1988, which banned the use of federal dollars to fund syringe exchange. It included two criteria for waiving that ban. It was that SEPs were proven effective in reducing HIV transmission and didn't increase drug use. So then there was all the research into that. 10 years later, I think it was April, there were a lot of demonstrations in town, the Surgeon General, there was a lit review of all the science that had taken place over the last 10 years, and it was all very conclusive that, in fact, we'd met the criteria. It was effective in reducing HIV transmission and not increasing drug use. Yay, this is great. This is working. But the Clinton administration, however, didn't exercise the waiver, finding the issue politically divisive. So they maintained the ban on the use of federal dollars, emphasizing more the local control issue, that if a jurisdiction decides that this is something we need to fund to fight the HIV epidemic locally, that's up to their discretion to use local state dollars. Now, remember the government control over DC that I mentioned? So in that same year, so in 1988, so we're talking about the FY '99 budget for the district, they prohibited the DC from spending any of its money on syringe exchange program. Now, mind you, Whitman Walker had been for about 2 years providing syringe exchange programs with district funds, a perfectly legal program supported by the community, supported by our own locally elected officials. It also prohibited any entity receiving federal local funds from operating syringe exchange programs. So not only could you not use the local dollars, but it also put in jeopardy any other local or federal funds you have. So if you are a large AIDS service organization, you have a lot of grants from the federal and local government. So those would be in jeopardy. So in October of '98, kind of preempting when this was going to be signed by the president and go into effect, the staff, those of us who were working at Whitman Walker Clinic for the needle exchange program, were laid off by Whitman Walker Clinic and hired by this new organization no one had heard of the day before called Prevention Works, that was created to continue the program under these new situations. Mind you, so there was a lot of media and fanfare about this. It got a lot of attention locally about this separation and all this stuff. So what didn't get attention in the media in October was that Prevention Works still didn't have the authority from the Department of Health to operate syringe exchange, because I was wondering what this was. So I called the health department, I talked to the director of the Department of Health, they had to call the legal counsel on the phone, because anybody, someone sitting at their computer and writing the authorization letter and someone signing it, those are salary dollars, those would be local dollars going to support syringe exchange in the District of Columbia. So anyway, we sort of worked that out with a call to the Washington Post, and that all worked out. So it took a couple of months, but it did come out. So some obstacles, immediate obstacles on this situation. Funding, obviously, we could only be funded with private funds. We had to research what are those available, and there are several, but they're not super plentiful. They certainly aren't into multiple-year grants. Collaborating with other community-based organizations was also very difficult. I mentioned how all the media attention about the separation from Whitman Walker and the threat to all their funds. Other programs were very wary of collaborating, even though they had in the past. They knew that this was a natural partnership, but that was another very difficult situation. Another odd thing, for a couple years, I go to meetings, kind of community meetings, planning meetings, your prevention meetings, and I'm talking about the needs for syringe exchange in the community. And so that was all fine. And then after the meeting's over, the government officials would come, oh, that's really great, I really support what you're doing, but I can't say it when the mic's on. So it was all a very interesting kind of situation here. So in, So in FY 2000, so the following year, the head of the committee that oversees the DC budget in the Congress on the House side wanted to continue that very strict restriction, which basically banned local, federal, and private dollars. President Clinton actually vetoed this bill twice on many issues, but he did actually particularly mention the onerous restriction on DC syringe exchange. So the compromise was to continue the local funding ban, but it would allow private funding as long as there was very strict sort of federal accounting of the federal dollars and local dollars from the funds for the syringe exchange. So yeah, everyone was really excited about taking on syringe exchange then. But so we continued with that. In 2000, there was a follow-up lit review from the Surgeon General and found again that syringe exchange is very effective in reducing HIV transmission, not increasing drug use, and in addition is very effective at actually getting people into drug treatment and keeping people in drug treatment when compared to areas where there weren't syringe exchange programs. Again, great, this is great, good news. So that has backlash on DC. Somehow good news about the effectiveness means, oh, we need to mess with syringe exchange in DC. So they added new restrictions to syringe exchange in DC. So there could be no syringe exchange within 1,000 feet of any school. And if there were any syringe exchange operating near a DC housing project, the district had to send a report to Congress every month on drug activity in that area. This is all so they learned not very much from those reports. So in fiscal year 2002, we have a new chair of the committee, Joe Nolenberg from Michigan. He continues the local funding, but he actually removes those other restrictions about the location and about the reports on drug use at the public housing projects. And in that same year, Mary Landrieu on the Senate side in the same committee there. So their processes are going on both sides. They're in the House and in the Senate. She passes, under her committee, they pass a bill that doesn't have any restriction on local funding for syringe exchange in DC. So that's new, because prior to that it had been in both versions. In conference, which is what happens when you have different language in the House bill and the Senate bill, they come to conference and they negotiate what's going to be in the bill that goes to the president. And so in that year, the House version won. And did every subsequent year. After that, the Senate really kept what we call a clean bill as far as the DC funding for needle exchange, but the House kept it in, and that's what came through. In 2007, things changed. We had Jose Serrano from the Bronx was chairing the committee in the House that oversees the DC budget, and he introduced a bill that didn't have the ban in it at all for local funding. On the House floor, however, Republican Bart Souter, a Republican from Indiana, was challenging this and trying to get the restriction back into the DC appropriations. And I can remember this day very well because it was like the weeks before, was making all the calls. Like, I'd never really thought these were very effective. These like, oh, everybody call your representative. But whew, I'm telling you, we called and it worked. I mean, we squeaked by and the amendment was defeated. And at the end of that year, President George Bush signed a 2008 appropriations bill that allowed DC to fund syringe exchange with local funds. So finally. So that was a big change. So in 2008, we had the creation of what the city, under the Department of Health, calls their DC NEX. Our then mayor, Adrian Fenty, promised $650,000 of DC funds for syringe exchange. At the beginning of 2008, he had a big press conference with one of those big checks, you know, sort of like the sweepstakes checks, for $300,000 for prevention works to expand its syringe exchange program. So that had been the program that I had been running before. I wasn't running it at that time, to expand its services. So it was all very, very exciting. And following that, in March, there was a request for applications, which was going to offer money for new programs to take on the syringe exchange programs. And in April, we added 3 new programs that would be offering syringe exchange programs. Family and medical counseling services, which was doing, Prevention Works has been a mobile, generally a van-based program, thus the van in front of the Congress in the opening picture. HIPS, which had been working with sex workers and was expanding to working a lot with, expanding its harm reduction work to drug users as well. And Bread for the City, a local health clinic. More recently, as we mentioned, the federal ban was removed temporarily, although then it was reinstated. Anyway. Updates on the local level, we have the portfolio with Prevention Works, which had been the original needle exchange program in Washington, D.C., actually closed in February of last year. Just wasn't able to survive as a small standing harm reduction organization. So the 3 other organizations still remain, and that's kind of still our harm reduction needle exchange portfolio. Family Medical, HIPS, and Bread for the City, which 2 of the programs, so Family Medical, you can actually visit downstairs. It's in the Global Village. One of their outreach vans is there, and you can go meet the fabulous staff there. HIPS is also in the Global Village, and Bread for the City is actually located about 5 blocks from here, so you can visit them as well. So I hope that, since 2007, we have actually, those programs are still getting pretty good support from the Department of Health. They're surviving with local dollars, although the truth is that you still have that looming challenge of Congress deciding that they're going to limit the funding again. So hopefully I won't be back here with an update that it's back in, that we can just sort of put this into the storybooks as this historic lesson and move on to really strengthening these services so they're effective, or more effective, in reducing HIV in the city. Thank you so much.
So thanks. We asked the presenters to cut things short so that there would be time for your questions. There are microphones in the aisles, and I would now invite you to come up and direct questions to the panelists. Ideally, we will take a few questions to allow to see the range of concerns. So you can just come forward and line up at the microphones if you have a question, and we will take you from different sides of the room. So first question from this side, and if I could ask you to identify yourself and where you come from, that would be great.
Thank you very much to the panel. I'm Kevin Reeby. I work for Health for Men in South Africa, Cape Town. And it's just a comment for Stephanie, the global map that we were shown, showing no needle exchange programs in South Africa and Southern Africa. Our program has actually been running a needle exchange program since 2010, when the federal ban was lifted. Obviously, we had to stop it when the federal ban came back. But we've actually continued service and now found alternative funding and have upscaled and will be upscaling the program further. So I guess a bit of good news that there actually is a program running successfully in Cape Town.
Thanks. And can we ask you, was that program funded by the U.S. government? When you say you had to stop it when the ban came back?
That depends if there's anybody from USAID in the room.
I think there may be, so...
No, the funding is separate, and we don't use USAID funding for needle exchange.
Thanks. Yeah, please.
Good afternoon. Peter Hartsock is my name. I'm on the National Institute on Drug Abuse. and I have had the albatross around my neck for over 25 years of pushing needle exchange research. Stephanie talked about the ban against research back in the bad old days. The way we broke through that ban was to get the research going in secret. We got it going at Yale University. Once people found out what it was, they tried to kill it, and then Congress asked the US GAO to do a report on it, and actually the GAO gave it total thumbs up. They asked the CDC to do an evaluation. CDC gave it total thumbs up. They asked the National Academy of Sciences to do an evaluation. I was a project officer on that too. Total thumbs up. The research was fantastic. It showed that it didn't create more crime or more drug abuse or whatever, and we didn't set out to show it would do anything. We set out to show, let the scientific chips fall where they would fall. If it was shown to be bad, we would say that. If it was in between, we would say that. Well, despite all of this research and a lot more, we still saw the ban against the federal money going to supporting services. But guess what? That the states took our research, the federally funded research, and they used it as a rationale for getting their own programs going. So this comes from the first talk which you gave, Steph, to the last one, which was a local scene. You get around by doing it locally and by using the best science possible, which we did fund through the federal government. There are ways to get things done, hopefully someday. Well, I've already said more than I should. But I appreciate what the panel is doing and what you all have done. We haven't seen the end of this, and it's a very volatile subject, even after all the research has shown what it's shown. And thank you all. Thank you.
Thank you, Peter.
Thanks. One more, and then we'll pause to let the panelists reflect back. Please.
Brian Kelly from Purdue University. My question is for Xiaobin, actually. A map you put up at one point showed a fairly uneven distribution of syringe exchange programs in China. The Northeast in particular looked fairly barren. I was hoping you could talk a little bit about the role of local politics in terms of how the distribution of syringe exchange programs has shaken out in China.
So Xiaobin, why don't you go first?
Yes, it's huge in China, and from the map we can see that there about 10 provinces there is no NEP program yet. So, but in the local government, if the HIV epidemic is heavy, the local government think, oh, NEP is okay to control the HIV epidemic among the drug user. But if there are less HIV positive drug user in local, maybe the local government has a different opinion on the NEP. And in some area, the CDC will provide the needle to the drug user directly, and in some area, the needle was provided by the pure education. Actually, they are drug user, and also some by the NGOs. Okay.
Thanks. And I don't know if any of the other panelists want to comment on the question that was raised about research. And how research, even if the federal ban is in place, for example, in the U.S., research can be used to bolster the local efforts. Steph, I don't know if you want to say anything about that.
That's true, but in fact, it's very difficult to get needle exchange evaluation research funded these days. In fact, I see that Dr. Friedman is at the mic, and he and others have been actively trying to do more research in this area, and the review panels at the NIH actually think that all the research has been done and policy needs to change, and obviously it's this vicious circle. Sam, did you want to make a comment?
Not to that.
Let me just say on that and on the South African colleague's comment that the US restriction is only on the purchase of needles. So technically, in fact, if you are doing needle exchange and you're buying the needles not with US money, but your US money can still go to, for example, pay for the peer outreach workers and things. I wouldn't want people to think that the situation that Paula described, where you can't do any needle exchange with any money, obtains to you if you're receiving US international AIDS dollars.
Well, that is true, Daniel, but I have heard that with the latest reinstatement of the congressional ban that local needle exchanges have had even a tougher time doing the work that they were doing with state and private funds. For example, the needle exchange, Clean Needles Now in Los Angeles, which is an excellent program, is having that very problem. So let's hope that at the state level that they will get wise, at least while we wait for the federal ban to be overturned yet again, and let's hope it's once and for all this time.
And I wanted to add as well that the research is definitely very helpful and useful in making our points, but with many of our opponents, they don't care about the research.
Okay, Dr. Friedman, would you
Yeah.
like to ask a question?
I would.
Please.
2 quick questions. Sam Friedman, I grew up in this town, by the way. First question is, we are not in a battle about science any more than the climatologists are. We're in a battle of power. So my first question is, how do we mobilize the power in those jurisdictions where clearly we need to mobilize power in order to get the needed harm reduction and other programs established, funded, and no longer harassed by the police or, as in Russia, even other forces? And my second question, as a follow-up to that, since this is a scientific congress, is what research would be helpful to get funded around the world in order to answer the first question reliably? That is, how can we do the research to figure out and to do experiments and learn from the experiments systematically about how we can get this situation to change?
Who will answer question? Stephanie? No?
Sam always asks the toughest questions. I think that it's obviously very difficult to change policy at this level. And I think hopefully in November we'll have some good news. We'll have a government voted in that's been supportive, and hopefully we'll have the leadership to move forward and to overturn the ban once and for all, as I mentioned. So first, I think that in an election year, that's going to be very critical. But I think that there are other things that can be done. I mean, we heard today very eloquently from Elton John about his history personally with addiction. And when we have people like that who have the courage and the leadership and the appeal to the public, or we have someone who stands up as a politician who says, you know, my son is an addict, and if he was denied access to sterile syringes, he'd be dead. I mean, that's, I think, very compelling. So I don't know, I'd like the other panelists to comment as well, but I do think that there is leaders that we can solicit for our cause.
And Stephanie, how about the second part of the question? What research questions should we be asking to figure out how to mobilize people more effectively?
Well, I think some of this work is actually being done by people like Don Desjardins and Brian Edlin have actually looked at opinion leaders and policymakers to try to see what are some of the factors that affect communities where change has taken place versus communities where change hasn't taken place. And I think that's very instructive.
Other panelists, thoughts on how to mobilize power to support harm reduction more effectively? Anya, Russia's in the middle of what has been an interesting sort of mass mobilization not around harm reduction. Have you engaged with that process of the demonstrations on the streets and things, and what do you feel like the future holds in that direction?
Yeah, we have. Like, we participate in all the street movement, and when there was like the Occupy Moscow camp, Occupy Abay camp, we did a lot of talking and seminars for people on harm reduction and what we're actually doing in Moscow. We also did one action on hepatitis C awareness and rapid testing for hepatitis C. So it's more and more like activists and advocates community that know about the issue and that are more compassionate with drug users now. But the problem is that the opposition in Russia is not very strong, so it's not really a like strong political movement. And of course, it's good that more people and more like media is supportive to our issue. It doesn't mean that we will be able to influence the policy, because now crazy things are going on in Russia, like the law that I mentioned on the NGOs that will be considered foreign agents now, or this anti-freedom of assembly laws that were passed just last week, or the law that will criminalize any public information about officials, or the law that will criminalize drug propaganda, and our website was closed just illegally in the beginning of the year because we were putting some drug propaganda on the website, which is WHO protocols and UNAIDS recommendations on substitution treatment. So it's a lot of crazy things are going on in Russia to which the opposition cannot resist, unfortunately, at the moment. So we hope that, it's good that people are supporting us, but it doesn't really give some realistic hope in terms of turning the political tide at the moment.
I think another effective tool which is underutilized is elected officials and policymakers actually talking with drug users themselves and hearing, I think just having a conversation and humanizing and not feeling so separate.
More question, please. Tatiana Dushko.
Thank you. Tatiana Dushko, International AIDS Alliance in Ukraine. My question is about treatment as prevention in the context of injecting drug user-driven epidemic. Very often it's about the choice, either the one or the second, that the discussion finally comes to. And in Ukraine, there are now some calls to reprogram harm reduction program to give a much stronger focus on prevention. So the question is about where the balance is.
To whom this question?
Maybe to Stephanie and maybe to yourself, Sergey Vasilyevich.
Okay.
To have more focus on what? Prevention.
You are interested in what must be focused on prevention, harm reduction, and treatment for IDs?
Yeah, the question is, very often when we discuss antiretroviral treatment and syringe exchange, it finally comes to the discussion either one or the other. And this is the way it is now happening in Ukraine.
Okay.
Should we reprogram the needle and syringe program to actually limit it to minimum, rather providing treatment to people who inject drugs?
Okay.
Thank you for restating your question, because now I understand it and I know what I think. I think all of us would agree that it should never be either or. In fact, nowadays we're talking about treatment as prevention in addition to prevention is prevention and treatment is treatment. But needle exchange programs, if they operate in a vacuum, like you saw with the Vancouver example that I spoke about briefly, that is limiting their ability to do more. And so there's a synergistic effect of adequate coverage of needle and syringe programs, opioid substitution therapy, and antiretroviral therapy. And the Dagenhart slide that I showed towards the end shows that if there's optimal coverage of all three, that they act in synergy to reduce incidence dramatically over the short term. So I think that, for example, needle exchange programs are often a site where people can receive antiretroviral therapy as well, and yet obviously if they aren't staffed with medical personnel, they're not going to have the ability to do so. But I think their capacity to be able to offer treatment as prevention would be outstanding, and in fact that would be an excellent research question to examine in the future.
Okay. Let me add a couple words. According to our study and our observation, we suggest that drug treatment incredibly effective in Ukraine in terms of prevention of HIV transmission, especially if we are talking about methadone program, buprenorphine program, and it's absolutely proved. But unfortunately, we have no so clear data about syringe exchange program in Ukraine, but I think it's because there are some different factors. First of them, this is difference between setting in Ukraine and in United States, where absolutely different conditions for drug users and access to syringes. Because in Ukraine, as you know, everybody can buy syringe in pharmacies. It's not the case in Canada or in United States. And second thing, it's we have very low information about quality of this service. Sometimes quality of service not very good. And additionally, I should say that coverage is very low. It's despite huge efforts which provide Global Fund, Alliance, many other organizations in Ukraine, coverage not really enough which can change situation. Because when we look at the community, the seroconversion still very high, 25, 28, in some regions just 38% of people become HIV positive. And methadone program help us to achieve much better results. And I think the problem, we need to develop this service and look at quality of service and coverage of the service.
Thank you. Just to add, I think there is enough data showing the effectiveness of syringe exchange program in Ukraine over the years, which indeed has the impact on the HIV/AIDS epidemic development in the country, which was outlined in the first presentation. Thank you.
Thanks. I'm Dr. Morin from Montreal, Canada. It's a question for Anya. I won't ask any political question. As there is so much opiate user and no methadone in Russia, can you tell us about this new drug called desomorphine crocodile? First, is it true there is so much crocodile in Russia? Second, did you see a difference between the needs for syringe, as they need much more injection? And would that be an argument for the government for you to ask for those needle exchange programs? Do you know about this drug? Thanks.
Yes, of course. Yes, crocodile is like the new kind of trend. Well, not really new trend. It's been around for 2 or 3 years now, in like massive, scale. In our program, we don't see many crocodile users. Like there are in Moscow, but it just like we don't reach out to this group. But throughout Russia, about 50% of opiate users are using crocodile or were using crocodile because just about like 1 month ago, the ministry put, there was a restriction on the sale of codeine-based drugs from the pharmacies before they were sold OTC. Now they will be not available OTC from the pharmacies, so we don't know where the drug scene will shift and will people still continue to use this drug or not. It does increase frequency of injection, and it does, as you probably know and you read about it, but it does increase the harms related to drugs, and basically people just, rot in just a couple of months or years. And we actually have clients from other cities whom we had to hospitalize in Moscow and who have to like replace their jaws, and it's really dangerous. But And our government is perfectly aware of the situation. It's a lot of press coverage to the crocodile like terror, but it does. I mean, the only moral that the government takes of any drug-related information is more scare and more terror towards drug users. So now they prohibited the sale of codeine, and I think the government will expect that the problem will just disappear, I guess.
Thank you.
So we'll take one more question, and then we will give the panelists any final words and come to a close. Please.
Hello, I'm Maxine Davis from the Dr. Peters Center in Vancouver, and I just wanted to comment on our Ukrainian friends' question around has there been any research around combining needle exchange and ARV treatment as prevention. And at the Dr. Peters Center, we're part of the British Columbia Stop AIDS program. And we have at the center, we have a combination of nursing care, supervised injection service, methadone, meals, a number of things. And with the Stop AIDS initiative, some preliminary research that's been done at the center shows that the engagement in treatment as prevention, the adherence rate got up from to 94% quite quickly, and it's a sustained engagement. The next step will be that the Canadian Institute of Health Research has just approved a 3-year study in looking at the model of care in terms of health outcomes and engagement. So we look forward to 3 years from now in sharing that. But I can tell you from a very personal perspective, it's an incredible combination that individuals who need clean needles, who need to have access to supervised injection service, actually it's a very high engagement in treatment as prevention.
Thanks. And just to add a little context to the Ukrainian colleague's question, there are some people, it's not about whether or not needle exchange can be combined with treatment to make, as they have done in Vancouver, but there are some people who are actually proposing that money be reprogrammed from needle exchange to treatment, taken away from one to the other. So for those of us who were at a session on Friday where Julio Montana, who is both involved in the Vancouver research, but also a great advocate for treatment as prevention, people put the question to him very bluntly, what do you think about this? And as Maxine, as you just said, he said that the evidence for treatment as prevention among drug users assumes a kind of comprehensive package of, with access to harm reduction, etc. There is not evidence as yet that treatment alone, and again, here we're talking about antiretroviral treatment, not methadone treatment. That treatment alone, he would not see the evidence as justifying moving all the money away from needle exchange. Okay, final words from the panelists. Anything you would like people to know before we close or to think about?
I just wanted to announce that today we will have an excellent presentation of the work of a photographer, Mikhail Friedman, who did a documentary on tuberculosis in Russia. And the presentation will be at 6:30 at the Global Village Human Rights Zone. So anyone who is interested in, in situation in Russia and tuberculosis, please come and join our presentation.
And all I want to do as a scientist who's also an activist is tell you to march tomorrow and join hands to ensure that we can overturn this congressional ban on federal funds that deny access to needle exchange, and also to ask the IAS to have future conferences where drug users and sex workers are as welcome as anybody else. Thank you.
Okay, thank you very much.